All right, y'all, we are in the home stretch. This is our very last lecture for drugs and behavior this semester. So we're going to finish up by talking about the different types of treatments for anxiety disorders. So anxiety is relieved by taking anxiolytics. So anxiolytics are what are known as anxiety reducing. So any good anxiolytic should relieve the feelings of tension and the worry and the signs of stress. Now, ideally, there should be minimal side effects, such as sedation. Now, when we talk about certain types of anxiolytics, one type of drug that we are going to mention that is anxiolytic is what is known as a sedative hypnotic drug. These are going to be depressants, and they do actually include things like barbiturates, benzodiazepines, and alcohol. All of these reduce neuron excitability largely through the actions related to GABA. So CNS depressants such as barbiturates, benzodiazepines, and alcohol all share some commonalities. So what you're kind of seeing here is that these anxiolytics will produce a very calm and relaxed state. Over time, you will see things like drowsiness, mental clouding, incoordination. At higher doses, we often call them hypnotics or sedatives because they do produce a relaxed state, but they can induce sleep as well. Now, because these are depressants at the very highest doses, they will induce coma and death largely through respiratory suppression. So we try our best to very highly control barbiturates, like such as things like phenobarbital, because they can be very deadly. You can take too much and end up dying due to respiratory suppression. Benzodiazepines are starting to get more attention paid to them because in addition to these issues, which will also happen with benzodiazepines, they are also very habit forming. You can develop a very strong physical dependence, and their withdrawal syndromes can be very difficult to deal with. And so one of the things that I've kind of noticed is that people are starting to become wary about prescribing things like Xanax, specifically because of the side effects, the addictiveness, and the withdrawal symptoms that benzodiazepines can produce. It's part of the reason why SSRIs are often prescribed first, or something like buspirone. They tend to be a little safer because they don't produce that respiratory depression. So how did these largely work? So anytime that we are talking about sedation, relaxation, and reducing neuron excitability, you know that GABA is probably going to be involved. GABA is one of our major inhibitory neurotransmitters. In particular, it's the GABA A receptors that seem to be really critical. These receptors regulate chloride channels. Now remember that chloride is a negative ion, and hyperpolarization can be due to an increased chloride flow into the cell. So this is how GABA reduces that anxiety or that excitability of neurons. It increases the amount of chloride flowing into ion channels, and as a result, it hyperpolarizes the cell, thus reducing its excitability. So what do benzodiazepines do? Benzodiazepines ultimately enhance the effects of GABA by permitting chloride channels opening. So what you're looking at here is the chloride current conductance. So here you can see with an influx of GABA, we get a pretty high chloride current conductance. That is enhanced when we include a benzodiazepine. Here we have GABA with a benzodiazepine and a benzodiazepine antagonist, so we've completely counteracted the effects of the benzodiazepine. And you can see that looks similar to straight GABA. When we include GABA a benzodiazepine and a GABA antagonist to counteract GABA, the benzodiazepines do nothing. So GABA is really, really critical here. Benzodiazepines need GABA to be able to create that hyperpolarization in cells and thus reduce their excitability. When there is no GABA, they really do nothing. So what about barbiturates? What do? They also increase the affinity of the GABA A receptor for GABA, and here's what's critical. So benzodiazepines don't do anything if there's no GABA. So they need GABA to be able to affect chloride channels opening. What makes barbiturates much more lethal is that they can open the chloride channel without GABA. So we get increased likelihood of depression and at larger doses, coma and death. So benzodiazepines can't do this. So while benzodiazepines are also dangerous in that they're habit forming and they have strong withdrawal symptoms, they're not lethal in the way that barbiturates might be. And because barbiturates are so deadly, because they can open the chloride channels and create that hyperpolarization without GABA, they have largely been replaced by benzodiazepines for treating anxiety disorders. So here are some duration of action and uses of major barbiturates. One of the things that you're going to notice is that a lot of these barbiturates are not used for anxiety. They are used for anesthetics for things like surgery or for sleep induction. So here we have different durations of action. So we have ultra short like thiopental or pentothal, Brevital or methoxetol. This is very highly lipid soluble. It has a very rapid onset but a short duration. So usually for people that are going under surgery, they may get some IV anesthetic before they get a deeper anesthetic that can last for several hours. We have short or intermediate with moderate lipid solubility. This includes amobarbital or Amytal, secobarbital or Seconal, and penobarbital or Nembutal. This lasts for several hours. It's critical for surgical anesthesia and sleep. And then for long periods, that includes phenobarbital or methobarbital. This is for prolonged sedation and seizure control, and in particular, phenobarbital can be incredibly deadly and dangerous if not used appropriately. So what are some of the side effects of barbiturates? First of all, what they do is they can reduce the amount of REM sleep. We will see things like mental clouding, loss of judgment, slowed reflex, not deflexes, and higher doses can lead to gross intoxication. Remember, these are central nervous system depressants, so they work similarly to how alcohol works in very high doses. Coma and death will result from respiratory depression. Do not combine them with alcohol. They do the exact same thing. So when you put them together, it enhances the effect of both. So why are barbiturates so dangerous? Your central nervous system neurons will adapt to the drug and they will become less responsive with chronic drug use. So the relaxation, the sedative effects will tend to show tolerance the more that you take it. But what does not show tolerance is the respiratory depression. So as the dose that is needed to have that desired effect of sedation and sleep increases, your therapeutic index becomes smaller. You're going to need to take more to get that effect of sedation or sleep or deep relaxation, but the respiratory depression doesn't change, and you are basically increasing the likelihood that you overdose, go into coma, and die due to that respiratory depression. So here's what you can kind of see here. So with your initial drug use, the margin of safety is pretty large. As you develop a tolerance, what ends up happening, note that the respiratory depression does not change over time, but your subjective desired effects do change. So that margin of safety decreases, leading to a greater likelihood of an overdose with time. So this led to the development of benzodiazepines. The first benzodiazepine to be introduced was chlordiazepoxide, or Librium, and it targeted anxiety without producing excessive sedation. It had a very low incidence of tolerance. Now, it does have a pretty bad withdrawal syndrome, but it's less severe than what you would see with barbiturates, and it had a very, very safe therapeutic index. So here we can actually see different types of benzodiazepines, and you can actually see some of the chemical similarities. So here is chlordiazepoxide, or Librium. Here's diazepam or Valium, triazolam or Halcion, flumazenil, and oxazepam or Serac. So you can see that they all have some pretty common areas showing some chemical similarities in structure. So benzodiazepines have a variety of different uses. You can't use them for deep anesthesia. You just can't. But you can use them for pre-surgical anesthesia. You can use them for dental work. I was actually told when I got my root canal that I could either have laughing gas or I could have Valium. But if I chose to take Valium, I could not drive there and I could not drive home alone. At the time, I lived alone. So I said, well, I'll take the nitrous oxide because, well, I live alone. Nobody can drive me. And this is largely done to relax the patient. Rohypnol, which is also a benzodiazepine, is marketed outside of the United States as a sleep aid, but it is occasionally used as a date rape drug when it is combined with alcohol. So if you've ever heard of somebody being roofied, they have been given Rohypnol. There are some other therapeutic uses for benzodiazepines. Longer acting ones can be very useful hypnotics to aid sleep and produce relaxation. Some of these benzodiazepines, because they work on GABA, are also very, very good muscle relaxants. Others can be anticonvulsants. Remember that epilepsy usually happens because of too much glutamate. So for somebody struggling with epilepsy, anticonvulsant drugs will often enhance GABA in some way. And they can also be used to prevent alcohol or barbiturate withdrawal symptoms without having to necessarily worry about cross tolerance because they work on slightly different mechanisms. So what are some of the effects of benzodiazepines? One of the things that's really great about them compared to barbiturates is that they have a higher therapeutic index. Now, having said that, despite the fact that they're safer, you do have to be careful with them. High doses will produce disorientation, cognitive impairment, and amnesia, but you won't get the respiratory depression that you would get with a barbiturate. Part of the reason that we kind of see this is that benzodiazepines don't really induce liver enzymes. So the more quickly that liver enzymes break down a drug, the greater tolerance that develops. So because these don't enhance liver enzymes, less tolerance will develop. They do tend to have a lower risk of dependence and abuse, but we do know that some will occur with chronic use. Abuse of benzodiazepines has occurred since the 1960s and 70s with Valium, and several of them, including Xanax, are actually classed as Schedule IV drugs. And because we know that they can be really habit-forming with people, one of the things that I've kind of seen is that people are very, very wary of prescribing a benzodiazepine when there are other options out there. So that leads to our second generation anxiolytics. So one of those is SSRIs. I'm not really going to talk much about them here because we talked about them with mood disorders. Other second generation anxiolytics do include buspirone or Buspar. Buspar, and I have actually taken this myself for about a year. One of the things that we find is that Buspar is less effective in reducing the physical symptoms that anxiety produces, but it's much, much better at dealing with the cognitive aspects related to worry and poor concentration. So what are some of the benefits of buspirone? So buspirone largely works on the serotonin 1A receptor. And because of that, for people who are struggling with depression as well as anxiety, it can be very, very useful because of that. Additionally, the anxiety reduction isn't accompanied by sedation, confusion, or mental clouding. For the first couple of weeks, you might experience a little bit of dizziness or ringing in the ears, but generally, that's really the worst of it. One of the downsides of it is that buspirone does take even longer than selective serotonin reuptake inhibitors to have its full effect. With Buspar, you do tend to see effects starting at about 4 weeks in, and then it's at its full effect at 6 weeks. So with buspirone, you really have to be patient. Additionally, it does not enhance depressant effects of the nervous system or alcohol or other CNS depressants. Having said that, you probably shouldn't be taking alcohol with antidepressants or buspirone anyway, just because it might enhance the it might cause problems, but not because it will be depressing the central nervous system. Now, what are the downsides? I kind of mentioned this already. The onset is very, very long, and its effectiveness in relieving anxiety is going to be less than you would find for a benzodiazepine. So this may be a first-line treatment, but for some people, this will not work, and they have no effect. So what we tend to find is that this is not going to be helpful for people who are taking it for situational anxiety. It's pretty good for generalized anxiety disorder. It's not going to be good for somebody who has panic disorder. It's not going to be good for somebody with situational anxiety when they find themselves in a situation that doesn't occur all the time, but occurs every so often, and they need that anxiety to come down quick. Buspirone's not really going to work that way. So it's better for GAD, but not much else. It can't be used as a substitution to treat alcohol or barbiturate withdrawal, because it works on completely different mechanisms. As I said, it works on the serotonin 1A receptor. Barbiturates and alcohol largely work on GABA, and this does not work on GABA at all. So you can't use it to treat those issues. Now, I will mention that SSRIs are often used for treating anxiety. Antidepressants are often used. The symptoms will be lessened, but not eliminated. And as I kind of mentioned, similar to buspirone, antidepressants will tend to take 2 to 6, usually closer to 4 weeks to become effective, versus benzodiazepines, which act immediately. So this will, again, be really good for somebody who has something like generalized anxiety disorder, but this won't necessarily work very well if you have something like panic disorder or situational anxiety that only pops up every now and then. So here are some of the different drugs that are used to treat various anxiety disorders, and here's what they are. So benzodiazepines can be used for all anxiety disorders. Tricyclics tend to be used for panic disorder, generalized anxiety, OCD, and PTSD. MAOIs for social phobia or panic disorder. These will tend to be less preferred than benzodiazepines because, remember, antidepressants require a little bit more time to kick in. SSRIs are often for things like social phobia. I disagree that it's well used for panic disorder. Again, these take a while to kick in, and they won't necessarily help you immediately with a panic attack, OCD, and PTSD. And then, like I said, buspirone tends to work better for GAD. It doesn't really work as well for panic disorder. So, folks, this is pretty much all I had for this lecture. I hope you have a wonderful day. I have already put your study guide up online. Not the study guide. I've put the final up. I will have the study guide up next week, and hopefully I will be scheduling a review session for you soon, and I will see you then. Bye.